Good morning and welcome to Medicine Grand Rounds. It's really a pleasure for me to introduce our two speakers today. First, Bart Caponi took his undergraduate degree at the University of Illinois in Chicago, medical school at the University of Illinois in Rockford, and then took his residency here. And he is currently a clinical assistant professor of medicine in the Division of Hospital Medicine. Bart's received a number of awards over the years. He was Phi Beta Kappa undergrad. He received the Lawrence G. Crocker Award for Outstanding Generalist Resident in 2008. And he's been awarded here just in a relatively short time from within and without our department. He received the Outstanding Consultant Award from the Emergency Medicine Residency Program for 2011-2008. He received the Hospitalist Teaching Award from the Division of Hospital Medicine in 2012 and also received the Evans-Glassroth Teaching Award in 2012. Joining him is his division head, Ann Sheehy. Ann took her undergraduate degree at Stanford and her medical degree at Mayo, where she also received an MS in clinical research. She undertook a year of OB/GYN residency at UT Southwestern before she saw the light and went to Johns Hopkins, where she trained in internal medicine. We were fortunate to recruit her here as a member of our faculty, and she has risen through the ranks and is currently clinical associate professor of medicine and director of the Division of Hospital Medicine. Ann has been involved in a number of ways and has been a good citizen in the school and the region. She's now going through the PLDP program. She has been elected Secretary-Treasurer of the Medical Board for our hospital, and she is the University of Wisconsin representative to the Dane County Medical Society Board. She's also an accomplished academic with 21 publications in the area of health services research and clinical care. She's authored 4 book chapters, and she also has won a number of awards. I'm always impressed by when student athletes become physicians, especially at a high level. She was a Pac-10 all-academic and qualified for the NCAAs in varsity track and cross country. She won the Department of Medicine Resident Teaching Award. She's voted as one of the top doctors in Madison, and she's also been awarded by our department for excellence in 2009 and 2011, so she may retire this award before long. She received the Evans-Glassroth Department of Medicine Inpatient Teacher of the Year Award, and in 2012 she received one of the great honors in this department, I think, and that's the Internal Medicine Residency Professionalism Award. So with that, we obviously have 2 real stars from our own department speaking to us today about an important issue that affects them but is important to all of us, and that's the hospitalized patient, hospitalized but not admitted, the era of observation status. I'm not sure exactly how you two are going to coordinate this, but welcome Drs. Caponi and Sheehy.
All right, thank you very much, Dr. Page. Neither Ann nor I have any relevant disclosures to report, so we'll get that out of the way. To start off, what do these patients have in common? The first one is an 85-year-old man found in a hoarder-type situation with mild confusion, presents to the emergency department. Nothing really truly objective on exam, but clearly can't go home, right? A 73-year-old with known COPD who presents with increased shortness of breath, diffuse wheezes, saturating 91% on room air, clearly in the throes of a COPD exacerbation. And then a 79-year-old man who presents with a low trauma, non-operative pubic ramus fracture. This guy can't walk, right? He's here in the emergency room. What do you do with him? What do these people have in common? Not a one of them meets inpatient criteria. Why is this important? Our patients are strongly affected by all this. Their bills, their access to benefits, any number of things change based on this inpatient versus observation status. Disposition options, where can they go in a safe fashion after they leave the hospital, is also affected by all of this. And then, of course, disposition pressures. How fast do we try to move these people through? Where are we routing them? What do we do? And I already mentioned changes in billing that affect the patient. The financial issues underlying all these things are large and permanent. They're not going anyplace. The healthcare system is hemorrhaging money in a lot of ways, so places are looking to cut costs. And these clinical and financial bottom lines matter to everyone. Your institution needs to be healthy to continue to help patients within the community. So teaching objectives for my little talk here. The first thing we're going to do is go through some introductions and definitions. I'm going to explain the difference between inpatient and observation status. I abbreviate observation OBS throughout the talk. I'm going to talk a little bit about InterQual. Some of you may have heard of the InterQual criteria, some perhaps not, but it comes up a lot. I'm going to talk about recovery audit contractors, which we refer to as RACs, and medical necessity, abbreviated as MN. And real quickly, I have a long form of this talk that goes on and on and on for several hours. It's endlessly fascinating on a lot of levels to someone like me. I'm going to say Medicare, and I'm going to talk about RAC. What you should all know up front is as Medicare goes, so all insurers go. So what I'm saying about Medicare could apply equally as well to Blue Cross Blue Shield or Medicaid or whatever. And RAC, I don't want to say the bad player, they're the major player in all of this, but there's any number of governmental organizations auditing charts. There's RACs, there's MACs, there's CERTs, there's the Office of the Inspector Generals, there's the various state bureaus. So when I'm saying Medicare and RAC, you can think of it as payor and auditors. So think broadly. And then I'm going to try and give you some tips about navigating observation status in 2012. And then Ann is going to give you some data about the University of Wisconsin Hospital's experience with observation status. So Medicare 101, something I didn't know a thing about until I was appointed to my current position about 6 months ago. When someone is an inpatient, their Medicare Part A benefit kicks in. And what that means is their inpatient services are covered. That's room, that's board, that's pay-per-view, that's all the stuff they get just by being in the hospital, a lot of testing, medications, and things like that. And there's one deductible in the first 60 days of care per year. So they max out their deductible, then they're not getting billed for any care provided. I don't want to say it's free, because it's not, but no bills. Part B also covers them, and Part B pays for their doctor services, so the charges I generate by rounding on the patient and writing a note every day, consultants, things like that. Some medications are covered, like IV infusions. And for every individual episode of care, Medicare Part B is associated with a 20% copay, and then there's a deductible per annum. And one of the important things we run into a lot is if one is an inpatient for 3 days, the 3 midnights, there's a nursing home benefit that Medicare will pay. So many of you in the crowd may recall what's this guy coming in for? 3-day stay, meaning that this person needs a nursing home and we want to get them their Medicare SNF benefit. If you are an outpatient, Part A does not kick in. And then Part B pays the same things as above, and of course there's no nursing home benefit. So what is this observation status business? Observation status was created in the early 1980s as a temporizing, money-saving measure for Medicare. Medicare's actual definition for observation status, this is taken directly out of their manual, is a well-defined set of specific and appropriate services, including ongoing short-term treatment, assessment, and reassessment, furnished while a decision is being made to admit or not to admit the patient. And Medicare also clearly states, as clearly as their verbiage is, about the timing. In the majority of cases, a decision to admit or discharge can be made in less than 48 hours, usually in less than 24 hours. In only rare and exceptional cases do reasonable and necessary outpatient observation services span more than 48 hours. So this timing stuff is important because many of us were brought up to believe, 23 hours stay, longer than 23 hours they must be inpatient. And the other thing there is outpatient services. When someone is observation in the hospital, they're an outpatient. So that's a very important point to remember. In summary, observation is intended for patients who need monitoring and further evaluation rather than a full admission. There's less paperwork, there's less charges to Medicare, et cetera, et cetera. When initially rolled out, observation only included 3 diagnoses: chest pain, congestive heart failure, and asthma. As we all know, these are diagnoses that can be evaluated and managed very expeditiously, typically. In 2008, Medicare decided that they would expand observation status to all diagnoses: variceal bleed, stroke, whatever. So now any diagnosis could potentially be managed in observation status. And again, observation has nothing to do with your actual physical location. If you're observation, you're outpatient. You might as well be sitting at U Station or East Clinic or in a field someplace. It's a metaphysical thing. You're under the roof, you're eating the food, you're watching the TV, you're talking to the doctors are providing the same care, but if you're observation by these rules, you are an outpatient. The criteria could charitably be described as somewhat arbitrary at best. And one thing that Medicare's criteria have not kept up with well is that improvements in care have dramatically changed what can be done as an outpatient. One thing that springs immediately to mind is cross-sectional imaging. In 1980, when observation definition was rolled out, they didn't have CT scans and MRIs, so we can evaluate patients much more dynamically and disposition them a lot faster than we could have when all this stuff was conceived. And another big problem we find is that these criteria, arbitrary as they are, also tend to not fit best medical practice. So InterQual, this comes up a lot. The nurse case managers may have said this to you. You may have heard of it in passing. What is InterQual? InterQual defines itself as the gold standard in evidence-based clinical decision support. And the actual manual consists of two pieces. There's a checklist and then there's a clinical resource. And if one actually reads the clinical resource in terms of diagnosis and management, it's not a bad thing. I think it compares favorably to UpToDate, although it's a little bit cumbersome to use. InterQual is used by the Centers for Medicare and Medicaid Services, 37 hospitals, 300 health plans, the military, and others, and it's considered the major guide to inpatient versus observation status. Really, how InterQual came about was back several decades ago when Medicare was all fee-for-service based. Care was applied very unequally across the country, and Medicare was finding that every patient admitted with community-acquired pneumonia, for example, was in the 95th percentile for severity of illness and charges and things like that. So InterQual evolved to fill this gap and apply guidelines and management a little bit more evenly. InterQual is a checklist. When we're talking about the clinical reference, okay, that's like an encyclopedia. The checklist portion comes in when a nurse case manager sits down and looks at the chart and starts clicking buttons for what the patient has and has not. And when they come and say, hey, this patient doesn't meet inpatient criteria, can we change them to observation? That's a large part of what this decision is being based on. It's a checklist, and physician judgment can trump that checklist, can trump those guidelines, if you make your judgment portion and your documentation clear. I'll talk more about this down the road, but this is also important, is in the end, the actual physician caring for the patient is the true final arbiter of their inpatient versus their observation status. For example, this is going strictly by the checklist. Somebody presents with an upper GI bleed. Their observation status, if they have melena or a positive gastric lavage, is that really standard of care anymore? If their hemoglobin is greater than 8.3, if their platelets are greater than 60,000 and they're treated with a proton pump inhibitor and they get an EGD that confirms an upper bleeding source, they are still observation if they didn't get blood and fluids. And it's not as simple as just giving them fluids. The fluids have to be at a certain rate, certain duration of time, things like that. There's a lot of very ticky-tacky rules here. They magically click over to inpatient status by InterQual if they have hematemesis, melena, or a positive gastric lavage, and then either their hemoglobin is less than 8.3, why 8.3 as opposed to 8.4 or 8.2? If their platelets are less than 60,000 or greater than 1 million, they get another point, and then they get IV fluids or blood, they get proton pump inhibitors, they're getting hemoglobins every 8 hours, they get an EGD that confirms a bleeding source. To a physician, the difference here is pretty minimal, of course, but to these billers, coders, to Medicare, to RAC, these are big things. And if we don't clearly explain why we're doing what we're doing, this patient might end up getting a huge bill where they're paying for 20% of everything as opposed to the other bill where Part A kicks in and some of their benefits are covered. In practical use, some conditions are almost always observation. For example, syncope, anything chest pain, anything pain-related actually, failure to thrive diagnoses, anything that one could describe as a rule-out, and laparoscopic surgeries are almost always observation by InterQual criteria. Auditors are paying particularly close attention to that. Fortunately, so are our case managers. Other things, extreme lengths of stay. So if somebody is in the hospital for months and months, that's going to get looked at. If somebody is in the hospital for 12 hours, that's going to get looked at. If their status gets changed, if they sat here for 14 hours as an observation and got clicked over to inpatient or vice versa, that's an easy thing for them to review. It's just a big waving flag saying, come look at me. And then mismatched status. If somebody's chief complaint and final diagnosis is syncope, but they were an inpatient, that's also going to get looked at in very short order. These days do matter, and we've got to get a proper status in place on our patients as soon as possible. And I'll make that clearer down the road as well. The long story short is your hospital cannot bill for services until the proper status order is written. Currently, we're exploiting something of a loophole, and if the team goes down and sees a patient in the emergency room at 10 p.m., pens the orders at 10:30, the patient gets admitted to the floor at 2 a.m., we're actually starting services at time zero being 10:30 p.m. So getting that order in as fast as possible is important. It affects the patient, and that's an important point here, is these patients are hugely affected by all of this. It helps us manage their expectations early. If they think they're coming in to get a nursing home placement and then they can't because their observation status, it helps the case managers to know that up front and be able to tell the patients that up front. It gives them more time to plan, if nothing else. And then your hospital's clinical and financial bottom lines are impacted very strongly by all of this. One important point is that 23-hour rule, and actually UW's HealthLink system had a best practice alert that fired the patient who's been here for greater than 23 hours, considered changing them to inpatient. And what we were finding on the case management side is a lot of patients were then getting changed over. That could, in an unkind world, be construed as fraudulent because the patient still didn't meet these criteria, arbitrary as they are, and firing that alert and changing that order for no reason, not only does it reset the clock in terms of charging for services, it also creates mismatches and things like that. That 23-hour rule has absolutely nothing useful to do with observation status these days, and Ann will really be able to explain why in her part of things. So what's driving all this? We are on the rack. From 2005 to 2008, Medicare performed a limited audit. They focused on New York, California, and Florida, which are states with large elderly populations and high rates of Medicare insurance and hospital bed usage. And they were looking for fraud. They were looking for ghost patients, double procedures, things like that. The intent was very good. They were trying to save the overburdened healthcare system money. They identified $1.03 billion in improper payments. Okay, fair enough. What they found was that 96% were overpayments provided to healthcare providers. So for whatever reason, the hospital or the physician or whatever got more money than they should have. Medicare then demanded this money back. These audits went permanent in 2006, and they went nationwide in 2010. I always find it a little curious that the audits were made permanent before the pilot was even done, but there we are. What is a RAC? RAC stands for Recovery Audit Contractor, and these are private corporations that contract with Medicare to review our charts, and they're paid on contingency. They're collecting from 7 to 10% of the billings they recapture for Medicare as their profit. So as you can imagine, they're not erring on the side of the hospital. They are very much interested in taking as many scalps as they can. At the University of Wisconsin, all charts are reviewed at admission for appropriate status, and this is what we're referring to as utilization review, or UR as I abbreviate it down the road. And currently, RAC is getting about 400 closed charts every 45 days. And we're pre-screening these before we submit them. When this started off, they had permission to pull a number of charts equivalent to 1% of our previous fiscal year's Medicare billings every 45 days, and that keeps going up and up and up. I've been doing utilization review for something like 9 months now, and we're up to 3 or 4% now. I actually forget because it's literally changing every couple months. In any case, we review the charts, we take out the ones that are clearly mismatches, things we're clearly going to lose, and then we submit them what you might call good charts. And then RAC reviews these charts, and then they either accept them, yes, you were right, okay, or they deny them. And then we have to start down the appeals process. Charts can be reviewed for two things. They can be reviewed for coding, which is the correct DRG, and some are reviewed for medical necessity of services provided, or MN. We're finding that the vast majority of our denials are for medical necessity, which is a big part of what a physician can alter or affect. I'll explain more about that down the road here. And what we're finding is that RAC is thus reviewing more and more and more charts for medical necessity and very few for coders. We have excellent coders, as it turns out. Denials can be appealed, and there are multiple levels of appeal with very strict deadlines on our side. If they go over the deadline, it's all okay. Nobody pays any attention. But if we miss a deadline by 15 seconds, sorry, Charlie, you lose. When a chart is denied, we can't collect any reimbursement whatsoever. So it's very much a shell game. As far as medical necessity goes, Medicare pays for reasonable and necessary interventions, which they define. And they define it as care that meets the standard of care, is clinically appropriate, and is not provided for the benefit or convenience of the payer, the patient, or the provider. They do not have to pay for interventions that they consider neither reasonable nor necessary. They establish the policies that determine payment status, and they're reviewing individual cases after the fact. And as you all well know from your clinical experience, what looks real reasonable and necessary at 3 in the morning when somebody's throwing up on you looks a lot different in a nice well-lit cubicle at 2 in the afternoon 6 months later. So again, the game is weighted towards them. One of the big problems here is that a test may be completely appropriate but not necessary in the Medicare sense, because medical necessity relates more to the setting of the service than to the need for the service. Common reasons we're seeing things being denied are lack of supporting documentation. A patient appears, they have complaints XYZ, and all of a sudden there's a several $1,000 stress test done and they're discharged and nobody really explains why. So that's lack of supporting documentation. Pre-existing conditions. One of my fortes, as it turns out, the patient shows up, I notice that their hemoglobin is 9.9. That's not right. Let's chase that. Well, if their hemoglobin's been 9.9 for several years, that was not necessary. That's a pre-existing condition. Lack of prior authorization for things that require prior authorization. Medicare has a list, private insurers have a list, and if you do one of these things without filing the correct paperwork, it's very easy for them to say, no, we're not paying for that, and the hospital eats the cost. Things they consider experimental, and one of the things that fascinates me is MS3 in Rockford, Illinois. The very first surgery on which I assisted was a laparoscopic Nissen fundoplication, and those are considered experimental. So even though they were doing it at a community hospital a decade ago, you know, that list does not necessarily reflect the most up-to-date reality of clinical care. Outpatient clinics are liable to medical necessity denials as well. Right now, they're focusing on the inpatient side because we are the fattest, dumbest gazelle at the water hole. We have the biggest fraction of patients, the biggest fraction of very expensive care and very expensive tests. So if you're sitting there saying to yourself, well, I don't work in the hospital, how does this apply to me? Oh, it does. And once they clean us up, they're going to come to get you too. So how do you navigate observation status? Documentation is the single most important thing you can do to help your patients and help your institution. You've got to make your rationale really clear to an auditor. These are not physicians reviewing these charts. These are administrative people who are looking for mismatches and looking for low-hanging fruit. If you want to fight this battle successfully, you've got to document what you've tried, what you're worried about, and what's going on. And again, these appropriate diagnoses and documentation significantly affect the patient's bottom line and then your hospital's clinical and financial bottom lines. And that's where things like the case mix index and the severity of illness and mortality play into things. I'll have some examples down the road, but urosepsis, a term we all know, we know exactly what urosepsis means, is in the same DRG as urinary tract infection. So if somebody dies of urosepsis, it looks like they died because it burned a little bit when they peed. If they were in septic shock from a urinary source, well, all of a sudden they have a 60 or 65% expected mortality and a length of stay of 45 days. So that simple terminology, urinary sepsis versus urosepsis, makes a really big difference in what the hospital is dealing with. I can't be clear enough about this. You can't ever embellish, exaggerate, or document something you didn't do. You had to be explicit. You had to explain what you're concerned about. It's okay to be wrong. We don't have crystal balls. They accept that, even if they don't like it. But as long as you're being reasonable, they're not going to take your license away or something. If a physician doesn't explicitly state what's going on, it can't be inferred from the documentation. When that coder is looking over that chart and figuring out the DRG, they can only deal with what's there. They can't say 1 + 1 + 1 = 3. All they can say is, oh, we have 1 and 1 and 1. So when they send you that coding clarification, there's a reason for that. Please respond. One example I heard at a conference which I attended was a $40,000 knee arthroplasty that was denied by Medicare because the documentation was awful. It was literally subjective, knee pain, objective, knee pain, assessment, knee pain, planned, knee replacement. The yacht note was something along the lines of, I successfully performed the greatest arthroplasty in the history of the known universe. And that got denied. And that only has to happen to you once before you shape up. And actually, our orthopedics department here does a tremendous job if you look at their clinic notes in particular. They'll say things like, the patient established care here 1 year ago for knee pain. A trial of scheduled NSAIDs and acetaminophen produced no relief. 3 intra-articular steroid injections provided no lasting benefit, nor did 6 months of physical therapy. Thus, knee arthroplasty is indicated. You can't argue with that. That's good documentation. A statement along the lines of admit to observation for rule out MI. That is just a disaster from a coding standpoint. Things that they're not necessarily dinging us for, but theoretically could. One cannot be admitted to observation. You can be brought in for observation, you can be observed, but you can't be admitted to observation because it's a contradiction in terms as far as Medicare is concerned. Rule out, garbage. As soon as you start saying rule out, there's no DRGs for rule out. If you say evaluation of chest pain, now that's a DRG. That's something we can work with. But anything rule out is just nonsense. Things you should pay attention to documenting. Short-term risk of death. This patient presents with a story concerning for crescendo angina. Despite the normal ECG and negative biomarkers, I am concerned about the patient's short-term risk of severe morbidity or mortality from acute coronary syndrome. Therefore, further urgent testing is indicated. They have a hard time arguing with something like that. Complexity. Think back to that upper GI bleed patient. That hemoglobin of 8.3 is completely arbitrary. And when I was talking about fluid rates, in HealthLink, when you order fluids and it clicks to 125 an hour as the default rate, that's the Medicare, that's the InterQual magic number. If they're getting fluids at 125, clearly they must need fluids that can't be provided as an outpatient. If it's 115, not so much. But if it's a tiny little old lady who has diastolic dysfunction and you don't think they can handle 125 an hour, and you document that, then they're on fluids and that's good enough. That's a checkbox. But if you just let them sit there at 75 an hour and don't explain why, they might as well not be on fluids at all. So complexities of the patients are very important. Comorbidities, of course, like I said, diastolic dysfunction. In my long-form talk, I can actually walk you through a patient example where the difference in severity of illness, cost to the hospital, and things like that are dramatically different if you call it pneumonia, history of heart failure versus aspiration pneumonia with decompensated systolic heart failure. The allowable length of stay there is weeks different. The hospital is getting 3 or 4 times as much billing. And the thing we do a poor job of is documenting that. Because for me, aspiration pneumonia versus community-acquired pneumonia, the difference is probably pretty minimal. I treat the patient the same, but the documentation doesn't necessarily reflect that. I already talked about this, tolerance for fluid rates, med doses. And the other thing is, so the case managers review a case, and then they come to me or they come to Sridevi Ganjareddy if they can't reconcile. The patient looks complex, and they should probably be inpatient, we think, but they don't meet InterQual criteria. We don't know what to do. So Sridevi and I provide the final arbitration. And I use an ideal clinic setting as my rule of thumb. And this ideal clinic is an amazing place, right? There's a magic unicorn to carry you from floor to floor, and there's no waiting for CT scans. They're read instantly, and you can get everything done. If I could get this patient evaluated, stabilized, treated appropriately in 18 hours in this ideal utopian clinic, then it's hard for me to make it be an inpatient. But if that can't be done, and you can't think about things like, oh, this poor old guy has no legs and can't get to that clinic. You can't think about that. You can't think about the patient can't afford gas money. If you could magically transport them from place to place and eliminate all those logistical difficulties, could it be done in a clinic? If so, the answer is probably observation. If not, then I'll make an argument for inpatient. When a patient comes in, please be sure to identify all the diseases they have on arrival. You can't just say, number 1, chest pain, number 2, diabetes, number 3, chronic issues per home management. That doesn't add anything to the patient's severity of illness. That doesn't build any kind of complexity case. You've got to really parse those out, please. I already said this, rule out, non-cardiac, ACS, these are not diagnoses. These are just words that don't make sense to Medicare. If it's chest pain, call it chest pain. If it's pleuritic chest pain, musculoskeletal chest pain, those are actual things. Non-cardiac chest pain is nothing, so that doesn't help. Remember that if a patient meets the SIRS criteria and they have a suspected or likely infection, that's sepsis. There's a big difference in DRG between fever or illness or malaise and sepsis, of course. And the other thing is suspected or likely. You don't have to be right. You just have to be reasonable. If somebody shows up and they don't have SIRS and you start calling them sepsis, you've got some splaining to do. But if you're being reasonable, even if nothing ever cultures out, that's still okay. They can still be septic. I already mentioned this. Urosepsis equals UTI. So do not say urosepsis. And then you should avoid abbreviations AMAP as much as possible. These non-standard abbreviations are nothing to billers, coders, auditors, lawyers, et cetera, et cetera. So just get rid of those abbreviations as much as you can. Again, can't emphasize it enough. It is okay to be wrong as long as you're being reasonable. The more you explain, the more reasonable you look. Auditors are looking at your history and physical, your discharge summary primarily, so make these documents comprehensive. They're not looking at nursing notes. They're not looking at the flow sheets. They're putting that burden on us, because if you think about it, if they give us 400 charts and say, all right, we're denying all these. If you want to appeal them, go ahead. We have to commit resources to reviewing this stuff and finding that one nurse's note that documented a SAT of 82%, which gives them a point on InterQual. So the more comprehensive you make your documentation, the better off we all are. What now? Currently, observation status is here to stay. It's saving Medicare loads of money. They've got no reason to change it. There is a lawsuit in progress against the Department of Health and Human Services because of the manifest unfairness of all this. And boy, I hope they win. It would be very nice. But right now, that's going to take years. If you're not sure about it, it's probably observation in the current environment. There's just nothing we can do about that. Be sure to document all the details of your case, why you're doing, what you think is going on, et cetera, et cetera. Will these complexity arguments hold up? We have no idea. I get called now, I apply my magic clinic ideal and say, clearly this is too complex to be managed on the outpatient side. We won't know until that chart gets audited, and that could be 5 years from now. So we'll see. One thing I can tell you is that the rules, or at least the interpretation and enforcement of the rules, is going to change again. I say it's a lot like pass interference. There's a rule on the book, then there's the situation on the field, and one referee's is not the same as every other referee's, and this is really a dynamic thing. The other thing we need to focus on is learning what observation status looks like so we can best help our patients and our institutions. And with that, I'll turn it over to Dr. Sheehy.
Great, thanks, Bart. So I'm going to talk a little bit about our patients here. And as Bart alluded to, I think the best way to kind of know what to do with observation status is to understand what our observation patients look like in detail. So I'll describe what the study we performed. I'll show why observation status is really a general medical issue. And then I'll specifically talk about general medical observation, and then we'll talk about summary and next steps. So really there's very little data. With all of these rules and regulations, there's very little published in the medical literature. There's the best paper that's been published was this year. It was published in Health Affairs in 2012, and it was a study that looked at Medicare observation stays from 2007 to 2009. And this study showed that observation stays increased from 2.3 to 2.9 per 1,000 Medicare beneficiaries per month. At the same period of time, the inpatient stays decreased from 23.9 to 22.5 stays per 1,000 beneficiaries per month, and the length of stay increased from 26 hours to 28 hours. So we felt like to improve observation care for our patients, providers, and our payers, we needed to better understand what observation looks like in detail, the issues and implications of observation status versus inpatient status, and how current observation practice actually compares with the CMS definition that Bart talked about. And I'll go back to that definition just as a reminder in a little bit. So again, we looked at all of our patients here, and just to tell you a little bit about the language I'll be using, encounters and stays are used to describe any inpatient or observation, start to finish hospitalization. As Bart talked about, admission really is a specific type of encounter or stay, refers only to inpatients. So I usually try to avoid the word admission. I also don't talk about readmissions when we talk about observation. We call them redundant encounters. It's kind of a negative connotation, but they're not readmissions. They're actually a re-encounter. So we looked at all of our encounters from July 1st of 2010 to December 31st of 2011, and we had 43,000 total encounters. About 90% were inpatient, 10% were observation. We did not include our OSS patients. These are typically a surgical subset, people that stay in a little bit of prolonged observation after a surgical procedure. And then we divided these patients into service groups. We looked at the medicine patients, and this is our general medicine patients, all of our GMed ward patients, hospitalists, non-teaching patients, and we included family medicine in that group too. Subspecialty non-surgical patients were our second group. These are services like cardiology, hematology, but also non-medicine subspecialty services like neurology and psychiatry. Our surgical services, and then our pediatric services. So we had 4 service groupers. And this actually is a complicated slide, but I think it contains a lot of information. On your left here is all of our observation patients. On the right is all the inpatients. And if you look at this, the blue is medicine on our OBS. Medicine takes up, and this is our general medicine patients, over half of our OBS patients are medicine. It's almost the same for surgery on the inpatient side. And I will point out here that there is 1,141 distinct observation codes in this study. So going back to that CMS definition of a well-defined subset of populations, it's really not what we're seeing in clinical practice. Over 1,000 distinct codes for 4,578 observation patients. That's a lot of different codes. This slide looks at prevalence by service group. So on the far left here, you have all. So again, 10% of all of our patients were OBS. The medicine patients, of all of our general medicine patients, 25% were observation, 75% were inpatient. This is a lot more as you go along the bottom compared to our subspecialty non-surgical services, surgery, and pediatrics. So this is really affecting our general medicine patients in a disproportionate way. Another aspect of this that's affecting our general medicine population in a disproportionate way is the length of stay. And the other part of the Medicare definition is that most observation care should be able to be resolved within 24 hours, the 23-hour OBS stay, and then only in rare and exceptional circumstances should it last greater than 48 hours. When you look at our all-comers here on the left, the blue is the proportion that's out in less than 24 hours. Only 44% of our all-comer OBS are leaving within 24 hours. The green on the top is the proportion that's staying longer than 48 hours, and the middle is the 24 to 48-hour length of stay. So 16.5% of all of our observation patients are staying longer than 48 hours. And again, when you look at the medicine subset, again, this is medicine, subspecialty surgical, surgery, and pediatrics, the fewest proportion of medicine patients are getting out within 24 hours, and the largest proportion are staying greater than 48 hours. So 26% of our medicine patients are staying longer than 48 hours. Again, this rare and exceptional definition by Medicare really is not what we're seeing here in clinical practice. The cost is pretty remarkable. Again, it's the same categories across the x-axis, all medicine, subspecialty non-surgical, surgery, and pediatrics. Where observation for our institution is a money loser. Our cost subtraction, cost minus reimbursement ratio for all comers is a minus 8.7% margin. Medicine is hugely negative for observation care. It's a negative 33% margin. Our subspecialty OBS and our surgical OBS have a positive margin. PEDS is just slightly negative. So I really think these slides show us that observation status is really a general medical issue. More observation care is done in our general medicine services than anywhere else. And as I showed you those 2 pie graphs, 53% of our observation care is done on the general medicine and family medicine services. General medicine has the highest percent observation. When you look at all of our medicine patients, 75% are inpatient, 25% are OBS. That's higher than any other specialty grouper in the hospital. General medicine has the most prolonged observation status. Again, 26.4% of our patients are staying longer than 48 hours. And the financial losses in medicine observation are really way outside what other services are seeing. This minus 33% margin is pretty remarkable. So we thought it was important to look at what does general medicine look like? What trends can we see in our medicine population? Why is it so costly? Why are these people staying longer? So we looked, based on this high-level kind of look, we thought that we should look at length of stay in our general medicine population as a first distinguishing factor. And there were 3 length of stay groups that we talked about: the less than 24-hour length of stay, 24 to 48 hours, and then this greater than 48-hour group. And then again, just a reminder, these patients were our general medicine teaching services, our hospitals non-teaching service, and our family medicine service. And then we also thought it was interesting to look at this, the older population, the group that was greater than 65, given the Medicare implications. And again, 2 pie graphs here. On the left is all of our medicine observation patients. On the right is our greater than 65-year population. And so when you look at this, again, you've seen this in a bar graph form, but just to kind of go through it again, 33% of our medicine leave in 24 hours or less. 26% are greater than 48 hours. When you look at the greater than 65 group, all of these numbers get just a little bit worse. The 24-hour group is a little smaller, and the greater than 48-hour group is a little bit bigger. The medicine patients staying greater than, or the age greater than 65, this was about 41% of all of our medicine observation stays. So it's a big group, a big subset of our population. The other thing I'll point out is our mean length of stay for medicine is 41 hours. If you look at our mean length of stay for all OBS in this hospital, it's 33 hours. So the length of stay is clearly shifted. Gets even worse in our elderly population. And when you look at the mean length of stay in this greater than 48-hour group, it's huge. It's not that these people are just staying 50 hours. These people are staying a lot longer. Mean length of stay in the over 48-hour group is 81 hours. In our over 65, it's 82 hours. And this really reflects the tail. We have observation patients 200, 250 hours, and so the mean is quite high in that group. Our diagnosis codes, I don't want to spend a lot of time on this, but if you look at, for all medicine observation, we have our top 3 listed in each of the time service groupers. Chest pain is our number 1 in the short stay observation. This is almost exclusively chest pain. This is almost exclusively chest pain. When you get to this greater than 48-hour group, you get to this general symptoms category. General symptoms includes things like syncope, but it also includes things like malaise and fatigue, dizziness and giddiness, a lot of these failure to thrive diagnoses. You get this earlier in their over 65 population. You still have chest pain in your less than 24-hour group, but you go to general symptoms a little earlier, and it's a bigger fraction of your patients. And actually, our number 1 independent diagnosis code in this group here, this greater than 48-hour group that's over age 65, is malaise and fatigue. And I guess just one other thing to say, we had 584 distinct general medicine observation codes. So again, just to talk about, again, to remind you what this definition is, this well-defined set of specific diagnoses, now what we're seeing, and especially in the medicine population. When you look at the timing, this less than 24-hour designation, and then this rare exceptional term in the greater than 48-hour group, again, now what we're seeing. And I think this is really important because if legislation is coming down hinging on this definition, if the definition really doesn't reflect what we're seeing in clinical practice, it's really going to be hard to have fair and equitable laws to help these patients with this definition kind of missing what we're seeing by such a large margin. So a couple other things to note in this group. The next several slides I'm going to show have the same setup. Across the x-axis, you're going to see less than 24 hours, the 24 to 48-hour group, and then the greater than 48-hour group. The blue line is always going to be all of our medicine patients, and the red line is our subset of patients that are greater than 65 years old. And if you look at this, our margin in our short stay OBS actually isn't that bad for our general medicine patients. We lose 5.5%, but that's better than our 8% loss that we have in all comers. It gets extremely negative once you get down to these greater than 48-hour stay. We have a negative 57.9% margin in our elderly patients when they're staying greater than 48 hours. The percent of government insurance also increases as length of stay increases for uncertain reasons. It could reflect disability in that group. There is an increasing medical assistance proportion in this group, and then with the some disabled patients having Medicare. So as you go up, Again, in this greater than 48-hour group, when you look at all the medicine patients, 53% have government payers. In the less than 24-hour group, that rises to 70% once you get into this prolonged length of stay group. And obviously, in the over 65 group, the majority of patients have government insurance. But again, you're looking at Medicare Part B, which not everybody has. So it's not 100%. Redundant stays, I mentioned this term before. These are not readmissions because these patients were never admitted. But when you look at patients that stay, again, in this greater than 48-hour category, the percent of patients in that group that have these redundant stays, that have repeat encounters during the study, it just goes up with length of stay. Two things that were somewhat unexpected. We found that age increased with length of stay, as did the percent of patients who were female. The age is a little bit younger in this group. As you get to the greater than 48-hour group, the age goes up for the medicine patients by about 8 years. When you look even at the over 65 group, the average age goes up about 2 years. When you look at the percent female, especially in the older group, the over 65 group, the proportion that are female reaches 70% in the over 48-hour group. And we think this is probably related to the fact that just based on epidemiology, women live longer than men. You're going to have more women in the over age 65 cohort, but then a lot of these people don't have a caregiver at home, and thus they're staying for more social reasons a lot of the time. We haven't drilled down into that, but we are going to be looking at that in the future. And then this is kind of what everybody on the wards feels. Being admitted on a Friday increases your length of stay because we don't have a lot of our placement options over the weekend. Some of our tests are not available. So when you look at the group of patients that stay longer than 48 hours, there's this huge spike in these Friday admissions. It just adds length of stay to the admission. And then I think the other thing that's interesting in this data set is to look at avoidable days. And avoidable days are this wonderful this concept that this institution uses. Our coordinated care group charts them. And they basically, case management charts these non-medical days. And they group them by cause, admission, which a typical one is admission criteria not met, meaning a patient never should have actually been placed in the hospital. They should have been managed in this ideal clinic setting instead. They are or due to hospital causes. So this is when a test or procedure isn't available and the patient stays an additional day because of that. And then discharge causes, and these are common. You have a patient that needs a nursing home, but there's no facility available, or the facility requests a delay. And we found that avoidable days were present in 4.7% of observation encounters and 5% of inpatient encounters, which is really remarkable because the inpatient length of stay is longer, and there's more opportunities for avoidable days. And you'll see this in the next slide. So when you look at all of our medicine OBS, we don't have very many avoidable days in these short stay OBS, which makes a lot of sense. It's hard to have an avoidable day when you're only having a day or two, but it jumps up greatly in these prolonged OBS patients. Really, you're looking at 14 to 15% of our patients in this prolonged OBS category have avoidable days. And when you look at our avoidable day reason, in all of our medicine cases, the number one reason is admission criteria not met. What does that mean? That means that these patients really never should have been brought to the hospital. It's kind of if there was a different outpatient resource for them, this could have prevented them coming into the hospital. And then another thing that's important with the Medicare implications that Bart alluded to, remember that our patients that are observation status are outpatients and they don't get the Medicare Part A nursing home benefit. This is really affecting our observation patients. The short stay patients less frequently go to need a nursing home at discharge. 6.9% of our medicine patients, 12% of our over age 65 patients. When you get to this prolonged observation category, a third of our over age 65 patients need a nursing home discharge. 21% of our all medicine patients. So looking at this, 31% of all of our Medicare patients here need a nursing home, but they fail to get that benefit because they're not inpatients. So just to summarize kind of what we've talked about quickly here, observation status is really a general medicine issue. The highest prevalence of OBS is in the medicine patients, the worst reimbursement, the longest length of stay. Prolonged medicine observation, which we define as this greater than 48-hour stay, is associated with cost and utilization problems. It's higher cost, lower cost to reimbursement ratio. There's more re-encounters of these redundant admissions. These patients have more government payers, and they more frequently discharge to facility. All of these things are very costly in the system for the patient and providers and institutions. As far as the demographics, these are older patients that are most hurt by observation status, and females are most likely to be hurt by observation status. The characteristics of hospitalization are also important. They're more likely to be admitted on Friday. They have more avoidable days. And age, all of these findings across the board are magnified in the older than 65 population. So again, it's this Medicare population that's really getting hit the hardest by this observation status designation. So targets for intervention, I think, really need to focus on the above-defined population, and we're really just scratching the surface, generating more questions than answers at this point with this data. But I also think it's worth telling you what we've done so far. Again, Bart talked about this BPA that suggested that status should be switched based on length of stay. That has been eliminated, which we're glad. We should all understand that length of stay really doesn't have a lot to do with observation status anymore. It's not 23-hour OBS. It's based on your criteria. Hospitalist lists, as of May 16th, we've customized our hospital medicine list to actually flag these OBS people in EPIC so we know who they are. I mean, it's difficult, actually. You know, Bart gave the example of the GI bleed patient. At face value, when you're going to round on that patient, it's actually kind of hard to know if they're OBS or inpatient, but we have these patients flagged so we can hopefully expedite care for these patients. And then we're trying to get the word out institution-wide. If you call us via the Access Center, and I just had a call 2 weeks ago from one of our providers wanting to admit a patient for placement, we're going to tell you that these patients are OBS. We're not saying we can't take these patients in, and actually there probably isn't a place for these patients right now, but we want you to know, and we want your patient to know before they come in for placement that actually they're not going to get placement. They're not going to get their 3-day pre-qualifying stay. So if you get a little bit of pushback from us, it's not pushback in saying we don't want to help you. It's more of an educational endeavor, so you know, and maybe that patient can be placed into a nursing home from their home instead, which is actually a much more cost-saving option for them. We also think that policy change is warranted, and I alluded to that, and Bart alluded to that. The CMS definition for observation really no longer fits what we're seeing in clinical practice. It's no longer well defined. Again, we had over 1,000 OBS codes for 4,578 stays. That's a lot of codes. InterQual is this 900-page manual that's very cumbersome. As a provider, I was on this last Sunday, and I had a patient that the son of the patient was really pressing me on whether this patient could be observation or not, and he had some great questions, and I'm pretty certain this patient wasn't going to be observation, but can I say for sure? You know, I don't have the InterQual in front of me, and I don't have, maybe there's a way we can justify this, but so it's not straightforward. We're doing the best we can, and actually case management helped me out greatly on Sunday with this case to kind of clarify, yeah, this patient was going to be observation, but this is a lot more of what we're seeing. That this is very complicated, not straightforward, but it's certainly not well defined. And then I think the length of stay argument is even more compelling. Observation care greater than 48 hours is no longer rare and exceptional. If you looked at the FENG study, they looked at the Medicare patients. Their average length of stay was 28 hours. And they didn't give specific numbers, but they talked about more and more patients staying longer than 48 hours. That's certainly what we're seeing at our institution. Again, 16% of all of our OBS patients are staying longer than 48 hours. 26% of our adult general medicine patients are staying longer than 48 hours. So really the rare and exceptional term is really no longer applicable to what we're seeing in observation care. I don't think practice change is going to shift enough to align with the CMS definition. I don't think we can make improvements in our care that's going to be able to shift people to this less than 24-hour bucket that they suggest. Again, when you looked at all comers, 44% of our patients stayed less than 24 hours. I just think 23-hour OBS is gone as far as our as an institution, as a country. So I really think we're going to need some policy changes as well as attention to fixing the things we can fix in our own system. And I just want to say thanks to Sridevi Gangretti. She's helped a lot with the observation status. I can't thank Dan Dexter of BPAD and Andrew LaRock, who's my assistant, enough. They spent nights and weekends helping me to get this data, and I just can't thank them enough for everything they did. Cindy Heidke, our division administrator, helped a lot with formatting and a lot of the review of this data. And then Sheila Fields, Barb Stanley, and Barb Legal have been invaluable resources for us in coordinated care. So thank you very much.
Thanks very much, Ann and Bart. We have a couple minutes for questions. I apologize for the construction noise. I don't know why it has to happen on Friday morning. The issue of getting it right, I've heard from both of you, is important. And I think to some degree people are scared of saying it's an admission if maybe it's going to be an observation or putting them on the observation first. But what really strikes me is the dilemma. For example, if a patient comes in for 3 days and they're on observation for 24 hours and then shifted to admission, that 3-day admission no longer qualifies for the nursing home benefits. So I think at least what I've heard from you and others is that not to be scared of calling something an admission up front if you think it truly qualifies as an admission, because you get that benefit. Could you comment on that briefly, and then please take questions from the audience, and please repeat the question for the videotape.
So the question, as I understand it, is it all right to make a judgment call? You're not sure if somebody's going to be observation versus inpatient, and you're worried about getting them their 3-day qualifying stay. That's probably the single toughest question to actually answer, because what's getting lost in all this, we're up here presenting all these numbers, talking about money to the institution and stuff. People are really being negatively impacted by this. So when I'm reviewing a case, I'm looking for any excuse I can find to make it inpatient, being aware of all these costs and benefits, and also wearing my utilization review hat and trying to be a good steward for the institution. I guess what I would say is, if you really think you can make a complexity argument, again, I could not possibly do this as an outpatient, then go ahead and make that change up front. UW at least has 24-hour on-call nurse case management. Really, it's daytimes, but there's always early evenings, weekends, and things. You can always page that person and ask for further guidance. Our hospitalists are as much experts in this as anyone, so don't be afraid to grab one of us. If I'm around, Sridevi was here earlier, and she's done a tremendous amount of work, mostly behind the scenes, reviewing the rack charts and things. Grab either of us and ask us. You can always shoot me a page if you like. Maybe I'll answer, maybe I won't. But make that change if you think you need to.
So, Bart, actually, my comment is relevant to that. So there's a fairly large geriatric literature that says that sometimes these non-specific symptoms are harbingers of medical catastrophe. And it really is a well-documented literature. You know, the sentinel fall that is sepsis, the delirium that is pneumonia. So would it be useful for you to partner with geriatrics and just give your people a few key references? Because as you said, they could be wrong, but there is a literature to document that you might upfront that admission a day earlier to do just what Dr. Page is suggesting.
That's, I think, further collaboration to help our patients is the most important thing.
Briefly.
Yes, the question was vague symptoms in geriatric population are often a harbinger of worse things to come, and would further collaboration with geriatrics improve patient outcomes? Is that day up front worth weeks and weeks later? And I think, yes, absolutely. I think further collaboration between all specialties is the best way to help our patients get through this morass until hopefully the laws change and allow the laws to reflect our clinical practice better. So yes. Joby?
From a patient perspective, it's my understanding that they are being billed the same regardless of whether it's ops or admission. Is that correct? And the second question is, are we writing off those charges as an institution, or are we bankrupting our patients?
So the question is, are patients being charged the same whether they're observation or inpatient? The answer to that is no. The bill they get is dramatically different from one to the other because of the presence or absence of the Part A benefit. And the follow-up question was, is the hospital writing off the costs that we're losing or passing it on to the patients? We are currently writing off all losses. there is a potential law change in the works. Right now, if we bill somebody as inpatient and our observation and RAC audits that case and denies it, we collect nothing for all that care provided. There's a potential policy change in the works that would then allow us to recoup for observation care provided at the time, which seems fair and reasonable, but more on that to come. Currently, we're not passing the costs on. Joel?
I hate to interrupt, but we're at the hour. Please come forward to ask these questions. They are important. I want to thank these physicians for a great Grand Rapids.
Thank you.
Sorry.
That's okay.